हाँ भाई बोलो। नहीं अभी नया है ना, आए तो मैं देख लेता हूँ ना। हाँ राम सुपर रेड्डी साहब आ गए अभी अभी मैं प्रमोट कर आगे प्रमोट कर लिया।
Dr. Gauri Devi, good evening.
Hello.
Hello.
Good evening, madam.
Yeah, I can't. Hi, Sharma. How are you?
Fine, madam.
Nice to be sharing the session.
Thank you, madam.
Virtual sharing the session.
A pleasure to share the session with you.
So, how are things at Manipal, your department?
Doing well.
Yeah, it's after many years. I think I came more than 10 years ago.
Yeah, exam.
As an examiner and as a speaker.
Yeah.
I came. Yeah.
Good evening, Sharma sir. Good evening. I am Ram Subba Reddy.
Namaskaram.
Namaskaram andi Ram Subba Reddy garu.
Namaskaram, madam. How are you?
I'm fine, thank you.
Fine. Okay. Nice.
సో మీరు ఎక్కడి నుంచి మాట్లాడుతున్నారండి?
మేడం ఇంట్లో నుంచే మేడం.
ఇంట్లో నుంచా? ఏంటో చాలా స్టేర్ కేసులు ఏవో లాట్ ఆఫ్ వర్క్.
టెర్రస్ మీదకి ఉంది రౌండ్ రౌండ్ స్టేర్ కేస్.
మీరు టెర్రస్ కి వెళ్ళారేంటి? మీరు టెర్రస్ నుంచి మాట్లాడుతున్నారా?
లేదు మేడం టెర్రస్ ఏం కాదు, టెర్రస్ కి వెళ్ళడానికి అది పైకి.
ఓకే ఓకే.
టెర్రస్ మీదకి వెళ్ళడానికి అది. సార్ ఎలా ఉన్నారు మేడం?
బాగున్నారండి, ఈస్ ఫైన్. సో మీరు ఎట్లా ఉంది డిపార్ట్మెంట్?
మా డిపార్ట్మెంట్ బాగుంది మేడం, బాగా నంబర్ ఆఫ్ కేసెస్ బాగా పెరిగినాయి, 50 వరకు రీచ్ అయినాయి ఓపీ.
ఓకే, వెరీ గుడ్.
కాకపోతే మాకు క్లినికల్ సైకాలజిస్ట్ ఇవ్వట్లేదు, చైల్డ్ సైకాలజిస్ట్ ఇవ్వట్లేదు, ఏమి కావట్లేదు స్టేట్ గవర్నమెంట్ లో.
మరి ఎట్లా మేనేజ్ చేస్తున్నారు? ఏమైనా టెంపరీగా
ఏంటంటే అర్లీ ఇంటర్వెన్షన్ స్టాఫ్ ఇచ్చారు మేడం, వాళ్ళు ఉన్నారు ఒక 13-14 మెంబర్స్ ఉన్నారు.
ఓకే.
దాంట్లో సైకాలజిస్ట్ ఉన్నారు, అర్లీ ఇంటర్వెన్షనిస్ట్ కు వాళ్ళు కూడా కొద్దిగా అసెస్ చేయగలరు, డిక్యూ వరకు అసెస్ చేయగలరు. దాంట్లో ఫిజియోథెరపీ, స్పీచ్ థెరపీ వీళ్ళంతా ఉన్నారు, కానీ వాళ్ళు రెగ్యులర్ గా ఉండట్లేదు మేడం. స్పీచ్ థెరపిస్ట్ వెళ్ళిపోయి దాదాపు ఒక 1 year అవుతా ఉంది, మళ్ళా రిక్రూట్ చేయట్లేదు.
ఆక్యుపేషన్ థెరపిస్ట్ వాళ్ళు ఉన్నారా? ఆక్యుపేషన్
ఆక్యుపేషన్ థెరపిస్ట్ ఉన్నారు మేడం.
వెరీ గుడ్.
అది రెగ్యులర్ అపాయింట్మెంట్ కింద వచ్చాడు ఒక ఆయన.
ఓకే, నైస్.
ఇది ఇంపార్టెంట్ ఏంటంటే క్లినికల్ సైకాలజిస్ట్, చైల్డ్ సైకాలజిస్ట్ ఇవ్వట్లేదు.
అంటే మీరు కూడా ఐఎంహెచ్ నుంచి అడగచ్చు కదా, కపుల్ ఆఫ్ డేస్ అట్లాగా.
ఐఎంహెచ్ నుంచి ఉన్నదే ఆయన కాంట్రాక్ట్ బేసిస్ మీద ఉన్నాడు.
ఓకే. ఇంకా కాంట్రాక్ట్ బేసిస్
ఆయన ఇంకా కాంట్రాక్ట్ బేసిస్ మేడం, దాదాపు చాలా రోజుల నుంచి ఉన్నాడు కదా.
10 years అయిపోయి ఉంటుంది.
10 years అయిపోయింది. అవి ఏవి మెటీరియలైజ్ కావట్లేదు, రెగ్యులర్ గా
రిక్రూట్మెంట్ అవ్వట్లేదు అనమాట.
అవట్లేదు.
యూ హ్యావ్ అనదర్, ఇప్పుడు 65 చేశారా?
అవును మేడం, 65 చేశాను కాబట్టి నాకు ఎక్స్టెన్షన్ వచ్చింది, లేకపోతే నేను లాస్ట్ ఇయర్ రిటైర్డ్ అయ్యేవాడిని.
Bhujanga sir's third memorial oration, and first and second, first one the awardee was Dr. K. Chandrasekhar. Second one is Dr. K. Ram Reddy garu. Third one, as you know all, our sir Dr. PSVN Sharma garu. And regarding Dr. Bhujanga garu, I would like to say two words. He was born on 17th October 1936, born to K. Venkat Lakshmi and Sitapati, who worked as a revenue inspector in Kadapa. He did his medical college and he pursued his PG in AIMS. He started psychiatry departments in Rangaraya Medical College, Guntur Medical College, Kurnool Medical College, and SVM Tirupati. And he was instrumental in establishing a psychiatry department in Mamta Medical College. And after retirement, he worked for almost 10 to 12 years, and he saw that everything is streamlined in the psychiatry department. So in his honor, we have started this memorial oration, and his wife, Dr. Rani Garu, is also a professor of pediatrics, and he has a daughter and a son who is an ophthalmologist. He expired on 16/6. Now I request Dr. Pawan Kulkarni to say a few words.
Sir. Good evening, sir. Thank you, sir. At the outset, I would like to thank Khammam Psychiatric Society, led by Satish Babu sir and Pramod sir, Vice President, Narayan Rao sir, Secretary, Raghuram Treasurer, and Virender sir, for having me here, and for having me here for this prestigious K. Bhujanga Rao sir Memorial Third Oration. And we know Khammam Psychiatric Society has been doing a great work, and I congratulate and wish them many more accolades. And I thank you for having me here, sir.
Thank you, Pawan. Now I request our State President, Ram Subbareddy Garu, to give his valuable message.
Sir, unmute Jan, sir. Ram Subbareddy, sir. Sir.
Am I audible?
Yes, sir. Yes, sir.
Okay, thank you. Respected President Satish Babu sir, Khammam Psychiatric Society, and Vice President Pramod sir, and Secretaries Dr. Virender and Dr. Narayan Rao Garu, and Treasurer Dr. Raghuram, and today's guest of honors Dr. Pawan Kulkarni, and President IMA Khammam Dr. Bhagam Krishna Rao Garu, and Secretary IMA Dr. T. Suresh Garu. And Bhujanga Rao sir was well-known person in the field of psychiatry. Sir started psychiatry departments in Rangaraya Medical College, Guntur, and Kurnool Medical Colleges, and also established psychiatry departments in SV Medical College, Tirupati, and Mamata Medical College, Khammam. And it's an honor given by Khammam Psychiatric Society to Bhujanga Rao sir by starting Oration on his name, for which sir is very much deserved. And it's happy to know that this year the Oration is awarded to Dr. P.V.S.N. Sharma Garu, who is having rich academic career with the areas of interest in genetics, rehabilitation, and community psychiatry. And at the same time, it's a pleasure to be part of this program when our teacher, Dr. Gauri Devi Madam, is chairing the session. And thank you, and thanks to one and all. I thank Dr. Satish Babu sir and his team for giving me this opportunity. Thank you, sir.
Thank you very much, sir. And here now, I would like to thank our Honorable Transport Minister and Chairman Mamata Educational Society, Sri Puvvad Ajay Kumar Garu, for sparing time to give a small message. Now we will play his message.
I'm happy to be informed that the Oration of Psychiatry Department Khammam Medical College, along with the IMA Khammam, being conducted on 29th of December in memory of Dr. Bhujanga Rao, who was the professor and head of the Department of Medical College, Department of Psychiatry for a long time. He was a renowned psychiatrist and academician in the fraternity of psychiatry. So there were two orations which took place earlier. Now the third orator, Dr. Sharma, is also coming from this particular hybrid virtual and physical permission. I wish all the participants good endeavor in this oration, and then I hope that good deliberations will take place in the oration. Bhujanga garu, who was very close to me personally also when he was the professor in the department of psychiatry. Thank you.
Thank you very much, sir. Now, I would like to say a few words about our sir. As you all know, Dr. PSVN Sharma sir is an eminent teacher, clinician, and academician. Sir has mentored lots of students who became competent psychiatrists and are rendering a lot of services to psychiatric patients all over the world. Sir is also very much interested in psychiatry rehabilitation. So today's topic is same. He has established Home Baleku, a rehabilitation center in Manipal, which is, if I'm not mistaken, around 34 bedded, and is doing a lot of service to the chronically ill psychiatric patients. I'm proud to say that I am also Sir's student from 92 to 95. Sir, now I invite you for your speech, sir. Before that, I would like to invite our chairperson, Dr. Gauri Devi Garu. Madam, I would like to introduce a small bit. Madam did her MD Psychiatry and 1 year senior residency in child psychiatry at NIMHANS, and was treating faculty at Institute of Mental Health and Nilofer Hospital for Children and Women for 22 years in government service. Held the post of professor and HOD of psychiatry in Usmania Medical College, Hyderabad, medical superintendent at Institute of Mental Health, Hyderabad. Was member secretary, State Mental Health Authority, State Nodal Officer, National Mental Health Program. Was examiner for psychiatry, clinical psychology, DM child psychiatry, and neurology at NIMHANS, Bangalore, NTR University of Health Sciences, Mahe, Manipal, and DNB Psychiatry. Presently, academic director of DNB coordinator for psychiatric training at Asha Hospital. Head of child psychiatry, conducting postdoctoral fellowship in child psychiatry under KNB University of Health Sciences, Warangal. Thank you, madam, for sparing your time to chair this session. Before starting our oration, I would like to ask our sir to accept our Bhujanga sir's memorial oration medal and memento and a small felicitation with shawl. I ask Dr. Aviram to hand over those things to sir. సార్ది పెట్టు శర్మ గారిది.
Thank you.
Sir, okay. Sir, did you receive medal, sir?
Yes.
Thank you, sir. Thank you. I didn't see shawl.
Shawl also has been put.
Thank you, sir. Now, I think Now I'll hand over the proceedings to our chairperson, Dr. Gauri Devi Madam.
Am I audible?
Yes, madam.
Respected Dr. Satish Babu, the President, Dr. Narayan Rao, the Secretary, Dr. Pramod, the Vice President, Dr. Raghuram, Treasurer, and others, and Dr. Ramasubba Reddy Garu, President, IPS Telangana Branch, Dr. Pavan Kulkarni, General Secretary, IPS State Branch of Telangana, Dr. Kishan Rao, Dr. Suresh, Secretary, IMA Khammam. It's my pleasure to be with you all on this prestigious third memorial oration of Sri late Bhujanga Rao Garu. And I met him in Khammam when he was heading the department there. I had the privilege of spending few hours there, and we had a lot of discussions about, how we can improve with the teaching programs. So he spent at least a couple of hours asking my opinions and how we can go about it. It's a way out when he was head of the department. So I take it as a privilege and honor to be the chairperson for his memorial oration. And I'm also happy that I'm chairing the session of Dr. PSVN Sharma, who was my class fellow in diploma, NIMHANS, when we were together. And it gives me great pleasure. I was with him on a couple of occasions as external examiner to his department, and also invited me to speak on the parenting techniques and the parenting aspects of child psychiatric branch. So I cherish memories both at NIMHANS and at KMC. And I know, I think before I introduce him as a general thing, I know him for the past so many years, and we continue, though physically we are not in touch with each other, but we do meet in the conferences. And I know him very, very serious, very sincere and meticulous worker. I always think I'm meticulous, but I always found he to be more meticulous than me. Whether it's teaching or the care of patients, he even has very keen interest in all those things. And I'm very glad I had been to his community center, the rehabilitation center, I think when it is in the budding stage many years ago. And I can see the zeal and enthusiasm he had, and he's very sincere, whatever he takes up. And not only that, he's a good researcher. And it's always nice to hear from people who keep their heart and soul into anything they do it. Many people do it, but I think when it is, from the heart, and you do, the hands-on experience, and when you do it, when you listen from them, I think you'll be really attracted towards what they say. You can take their words as very genuine. So from Madurai, Ramasubramaniam, and various other people from different parts of the country, the rehabilitation, their experiences, it talks about their innovative their thoughts, and then the methods that they put into the effort. So that's something interesting about it. And just to introduce him to others, this is my personal experience and my impression about Dr. Sharma. And he has done his MBBS from Maulana Azad Medical College, New Delhi. And later he did diploma from NIMHANS, where I studied with him. And later I continued in NIMHANS, but he went to PGI Chandigarh, where he did his MD Psychiatry. And then he came back to NIMHANS. He was senior resident when I was in child psychiatry. He was senior resident in adult psychiatry, as well as rehabilitation psychiatry. I'm sure he has done with Dr. Gopinath, our great teacher, and who is always, is quite silent, but full of, energy, but he doesn't show, but it is always seen in action. So he did with him. Later on, for a short while, he was in Ranchi CIP. Then in 1988, he came to Manipal, where, I mean, he set up the department and I can see the department grow. And now he's HOD and he is involved in various research activities, multicentric activities. And he guided quite a few students, almost, 37 MD dissertations and 11 PhDs. And he had 131 publications in the psychiatric journal, peer-reviewed journals. And he had 84 invited lectures and orations in the professional bodies. I'm sure his oration, whatever topics he takes, I'm sure it talks about the depth of his knowledge and the vast experience he has and the passion towards the field of psychiatry and the care of patients with mental illness. So with this brief introduction, I call upon PSVN Sharma to deliver his oration in the memory of Sri Bhujanga Rao Garu. And I know that he is going to speak on rehabilitation. I don't want to give any introduction about rehabilitation. I would like to listen to him. And since it is oration, there will not be any questions. And I request all the audience to be very keen and absorb whatever he says, which is going to be interesting. So, yeah, over to you, Dr. Sharma.
Madam, before that, 1 minute, madam.
Yeah.
Citation is there. Dr. Narayana will read it.
Okay.
I'm sorry for 2 minutes delay.
Khammam Psychiatric Society citation in honor of Dr. PSV Sharma. Dr. PSV Sharma is a renowned psychiatrist. He is currently working as a professor at Kasturba Medical College, Manipal. He graduated from Maulana Azad Medical College, New Delhi. He finished his DPM in 1981 from NIMHANS, Bangalore, and postgraduate degree in MD Psychiatry from PGI Chandigarh in 84. Then Sir joined as a senior resident at Kasturba Medical College, Manipal, Karnataka from 1984, where he thrived in his academic and professional career and was the head of Department of Psychiatry from 93 to 2018. During his tenure as HOD, he played pivotal role in inception and establishment of Rehabilitation Center for chronically ill psychiatric patients. He had more than 131 publications in peer-reviewed national and international journals. His research interests include rehabilitation, culture, and psychiatry, community mental health. He has been a clinical practitioner for more than 40 years and has been a teacher for most of it. He trained countless number of undergraduates, postgraduates in clinical psychiatry and how to rehabilitate people with chronic mental illness. He acted as a guide for 37 MD and 11 PhD dissertations. He gave more than 80 lectures at various seminars and conferences. He was honored with multiple orations and awards. Khammam Psychiatric Society felicitates Dr. PSV Sharma with Dr. K. Bhujanga Rao Memorial Award on 29th November 2021 in Khammam. Thank you.
Yes, madam.
Yeah.
Yes, madam. Now,
Yeah, now over to Dr. Sharma for his. Yeah.
Thank you. I just try to get my slide onto the computer, which is always a dicey thing for me. And is it? Oh, wait a minute. Where is it? This is always difficult for me. Okay. Is the slide visible, Dr. Gauri Devi?
Yeah, it is visible. You are audible and visible.
Fine.
Yes, sir.
Thank you very much for giving me this opportunity, talking in an oration for a very, very senior psychiatrist from AP. I met Dr. Bhujanga very long ago in Guntur, in the medical college, where I had gone for an exam and as a young examiner, and he was there as a very senior examiner. I heard a lot about him, but since I have not been working as a psychiatrist in Andhra or Telangana these days very much, so my experiences are very limited. However, I would like to express my great gratitude to the Khammam Psychiatric Society for having called me over and bestowing this honor on me. Of course, I am very grateful that you've chosen Gauri Devi as my chairperson. As she mentioned, that we are batchmates in NIMANS, and we've been in contact here and there, off and on in academic circles and so on. So it's very pleasant to have a reassuring person on your side, the chairperson on your side. That's nice. Satish Babu, of course, is our own. He's an alumnus of our department, and we're very proud of his achievements. And thank you, all of you in your society, for having me over. Now, I have chosen this particular topic because it's something of an interest for me. As Dr. Gauri Devi was saying, that way back in 2000, when was it? So long ago, 1981, after DPM, I was a senior resident in NIMANS for a short while in Dr. Gopinath's unit, and then I also worked with him in the back wards for rehabilitation. I finished my MD in PGI and came back and again joined this unit in the adult unit as well as in rehabilitation. When I went to Ranchi, I had an acute ward. I also had what they call Freud ward, which is a back ward. And so my association with people with severe mental illnesses, chronic mental illnesses, has been as chronic as my age. Now, giving you a brief overview of what I would like to share with you today, I would like to talk about the introduction to psychiatric rehabilitation goals and principles. A little bit about what we call as the recovery model, which is talked about these days. And then how do you assess and make a rehabilitation plan? And then what are the specific interventions in rehabilitation care which are evidence-based? And then residential or transitional facilities, and then role of vocational rehabilitation, then the need for a multidisciplinary team, how to evaluate a rehabilitation program, and finally a little bit, not to boast, but a little bit about the Manipal experience in what we have been doing in the past decade or so. So rehabilitation is essentially a systematic utilization of a combination of specific modalities to assist in the community rehabilitation of persons with psychiatric disabilities. It's invariably a combination. You cannot do psychiatric rehabilitation with just medication or just counseling or just any one thing. The problems are too long-standing. There are too many layers of problems. So you need a multimodal sort of approach for rehabilitation. The therapeutic approach should encourage a mentally ill person to develop the fullest capacities through learning and environmental support. So there are two things here. We're not here talking about control of hallucinations, delusions, formal thought disorder, etc. That will come a little later. But the fullest possible capacities to be achieved by learning through various means. I will try to talk about that a little bit. And also environmental supports within the family, in the community, and in the psychiatric care services. That is important. There has been a little bit of controversy about whether it is psychiatric rehabilitation or psychosocial rehabilitation, and people on both sides of the fence have their own arguments for and against. I will not get into the semantics of it. I'm looking at it as the same thing. But the important thing, as I mentioned, is that there should be a multidisciplinary and a multi-agency collaboration. The agencies are essentially community agencies. They could be governmental agencies, non-governmental agencies, or whatever. It could be religious agencies, but you need to have multi-agency collaboration because those agencies are in the community, and you're going to put this person back into the community. So the community should be able to accept this person. So it's a fairly sort of large goal that we have in psychiatric rehabilitation. So the goals are to develop empowerment of the individual and to produce some amount of healing and also hope in the clients. That's important. It's very important to get the client on board. Interventions which impact disability, which reduce disability, are what we will be looking at. And at times, you have to adjust the environment also to decrease the impact of the handicap. So you're doing both. You're trying to reduce the disability or handicap at the individual level, but you try, if possible, to change the environmental circumstances also. So when we talk about affirmative action in America or supportive action by the government or the state, we're basically talking about environmental changes to decrease the impact of the handicap. Unfortunately, one has to admit that it is an often forgotten need in mental health services. We all know that maybe 10 to 15% of people with schizophrenia, definitely another 10 to 15% people of bipolar disorder, perhaps 5 to 10% people with depression, chronic depression, OCD, so on and so forth. And I'm not even going into substance use disorders. All of them have chronic, devastating illnesses which require some help beyond pills, injections, and ECT. And that's the sort of thing that is often forgotten in the public domain, as well as sometimes in the mental health professionals domain. And this requires empowerment in many places. People who are empowered from the public and people who have recovered from chronic mental illnesses are the people who advocate for rehabilitation services. But at the same time, just as every person is different and every person's schizophrenia is different and every person's disability is different, so every person's rehabilitation also has to be different. So the whole recipe has to be tailor-made. And of course, people's behavior also varies from one situation to another, and hence a flexibility in your designing of the rehabilitation program is needed. Although my saying it is easy, but it's a fairly difficult task. We try to foster, in the principles of rehabilitation, we try to foster self-determination as far as possible. We need to attend to the client's choices and the client's culture. It's extremely important for us to note that, and to focus on real world and the strengths of the client, the real world demands. What's the world that he or she is going to go back into, and what are his strengths or her strengths? Many times we need to do skills training, a variety of skills training. We'll talk briefly about that later on. And as I said, environmental modification and supports have to be put into place where needed. And it's very important to integrate psychiatric rehabilitation with other treatments. What I mean is medical treatments in psychiatry, treatments for medical disorders, treatments for substance use disorders. All these things need to be integrated. You cannot do it piecemeal. It doesn't help usually. And of course, a multidisciplinary team functions best in this sort of a situation. And there is something which I will be talking about, that community and recovery orientation, which is being fostered a lot abroad. It is not caught on yet, excepting for people who are in very highly specialized centers. But this is the sort of orientation that is being talked about abroad. And it's very important in psychiatric rehabilitation that you build and maintain a long-term therapeutic alliance. Without that, things won't work. So where do we start rehabilitation? Actually, it should start at the time of first contact with the mental health service provider. I say that the first time you see somebody with a panic disorder or schizophrenia or a depression or a bipolar disorder, that's when the rehabilitation work actually starts. we should not conceptualize rehabilitation as something that happens in a back ward in a mental hospital or in a purely residential rehabilitation center or in a daycare center which is dealing with people who have chronic mental illness. No, those are all outliers. We should start thinking about rehabilitation at the time when we first make a diagnosis. That's important. Now, coming to the recovery model, this is a relatively new direction in rehabilitation. Relatively, it's all more than a decade old actually. It involves a collaboration and a partnership and choice given to the client. So it's not an imposition. Generally, we take the paternalistic medical model of imposing things on clients, but this does not involve that. It is much more collaborative in nature. There's no assumption of cure. Nobody is saying that your hallucinations must go or your delusions must go. In the sense of escaping from symptoms or impairment does not happen, because we know that many people do retain some symptoms, some impairments. The point is that both the doctor and the rehabilitation person and the client needs to understand that sometimes one needs to learn to live with those deficits. And again, regaining lost roles as far as possible, because a person who's been mentally ill for a very long time, his roles shrink in society and his own home. He tries to regain some of those, but then other people have taken over those roles. So he may have to try to regain lost roles and also acquire new roles because he's moved on. He's 5 years older, 10 years older. So he's in a different place in the life cycle. Now, recovery has probably two meanings. One is the clinical social recovery, and the other is the personal existential recovery. I won't go into the philosophy of that, but there is a lot of debate regarding this. But you can operationalize recovery. One way is remission of symptoms as best possible, not necessarily a PANSS score of 7 or 10. No, we're not aiming at that. And working or studying in normative settings, being able to go back to a normative setting for work or study, ability for independent or normative living, involving in social activities with peers which are age appropriate, culture appropriate, maintaining a cordial family contacts, whatever is possible with his family or her family, normative recreational activities, and developing some amount of resilience and using problem-solving skills to face the problems that usually occur in day-to-day living. Achieving, of course, subjective satisfaction and self-esteem with all this. So this is how you can operationalize the recovery model or the recovery goals, and then see how you can push your patient along with you towards them. Now, this is just an Eaton study to show you that it is necessary to start rehabilitation interventions very early. If you take the case of psychosis like schizophrenia, you need to probably start off fairly early, the moment the first episode has occurred itself, because there's a sizable number of people who go on to have further episodes with increasing deficits. What do we do in the initial assessment? Quality of life is related to meeting the rehabilitation needs of the client. Okay, so he or she is happy when we meet whatever his or her needs are. The clients often have different needs from our perception. Generally, we tend to focus more on delusions, hallucinations, formal thought disorder. Is he looking after himself? Is he eating his medicines or not? So on and so forth, which are very important. But at the same time, the client may have his or her own perceptions of what he or she wants to do, or what he or she wants to achieve. So we need to be sensitive about those. Otherwise, the contract between us and the client won't work. It won't happen. Then, so we need a collaborative assessment, collaboration between the mental health provider, the client, also in our sort of setting, the family members, and anyone else who is involved. Important is that diagnosis is not a reliable index of needs. Again, I'm emphasizing this. I mean, just because a person has a diagnosis of bipolar affective disorder does not mean that the need is only to control mania and control depression. There can be a lot of other things that happen between the mania and depression in him. So diagnosis is not a reliable index of needs. And we need to focus on the client's strengths because that's what he has. Okay, that is his background, or that is what he or she has. So we need to prop that up and focus on those strengths, whatever they may be. Maybe the job he was holding earlier on, the level of education he had, the skills he had, or whatever. And there should be a congruence of the rehabilitation plan with the coping style, and that is necessary. And we need to use some standardized assessment methods in our rehabilitation setting, because otherwise we will end up with very subjective statements like he's improved, he's not improved, and so on. And of course, working in a rehabilitation setting, one is obviously biased towards seeing things as improved. So standardized assessment methods would be preferred, and there can, however, be limitations. I agree to standardized methods. You might not have the same rater doing the rating every time. As a busy clinician, you may not have the time, and so on. So these are problems. There are problems that need to be solved if possible. Now, the strengths of the assessment, I mean, what do you focus on? The strengths, the aesthetics of the individual. Does he have a sense of humor? Can he develop intimate relationships, he or she, I'm sorry. Is there a role of spirituality? How are the communication skills? Are the communication skills still intact? What is the background, educational and employment achievement or skills of this individual? What are the occupational skills of this individual? What are the recreational skills? These are the things that you will consider when you make the rehabilitation plan. As I mentioned earlier, it's a collaborative document. It's a reference document for both the mental health person and also the client. Okay, because rehabilitation work goes on for months and months and months. Many times we sort of lose sight of what we started off with. So we need this document to pull us back and say, hey, look, you wanted to do this to start with. It's an operational document, and it focuses again on the strengths of the individual. It is needed to review the progress periodically to know what is happening right or wrong with the treatment. And there are difficulties, however, in maintaining fidelity to the rehabilitation plan. Difficulties are many. I mean, the natural course of the illness and the non-response of the illness itself is a huge difficulty. But apart from that, the practitioner focus, the focus more on the mental health person, can become a difficulty. Sometimes we set up very confusing goals or strategies. And you know, like we know that the individual has passed only till 9th or 7th or 8th standard 10 years ago, and we set up the goal that he needs to go and get computer educated and do a BCA. Now, that sort of a goal, and then a strategy of putting him into a college where BCA is taught, may not be successful because of the interregnum of 10 years where a lot of skills have been lost. So there is a problem in maintaining fidelity to the original rehabilitation plan. Again, we could make over ambitious goals or targets, and that becomes a problem. Or we may set vague targets, again a problem. So it's difficult to make a rehabilitation plan, but even more difficult to maintain fidelity with it when we go on in managing or treating a client with these needs. I'll tell a little bit about specific interventions that are being used now in rehabilitation care. And forgive me, but this is focused a little more towards the students, the postgraduates who might be attending this. The senior people will obviously know all this before, so my apologies for that. We have the important things are that to establish a working relationship with the patient or the client, an agreement on confidentiality, a time and space to discuss emotional issues related to the whole rehabilitation process, whether it is at home, at a halfway home, as a daycare center, in a residential place, or whatever. They need the interventions which will require the support of the family in our setting and the state in places like America or so on. Enhancement of problem-solving skills, agreement on relapse prevention strategies. We know these conditions relapse. We know that a sizable number of them come back with symptoms. So how to recognize symptoms, how to prevent relapse or understand that the relapse is happening and seek help quickly. These strategies also need to be agreed upon. Effective communication patterns is something that needs to be looked at, and ongoing nature of the relationship. As I mentioned earlier, this is a long-term commitment. This is not done in 3 months, 6 months, panic disorder in the OPD or depression, ordinary depression in the OPD and so on. This relationship may go on for years. One of the things, common things that we look at is social skills training. This has been around for several decades. In between, it was much maligned as useless, but it has come back. It uses both communication and behavioral paradigms, and it broadens the repertoire of social skills in our clients. So some people say that it may also decrease psychotic symptoms related to social dysfunction, but this is a little questionable. Remember that pre-treatment symptoms are not a predictor of outcomes, but poor memory is definitely a predictor of poor outcome in social skills training. And once the person has been through a social skills training program, the effect may last from several months to a year, but if you have booster sessions, it goes on much longer. It's probably more effective and more economical to do social skills training in a group mode. If you have several people who have the same problem, putting them together, it works better. Extremely important is that it works best when you embed it in a rehabilitation plan. That means many other things are happening and social skills training also happens. It performs best. And there are many training models for social skills training. Even many Indian language models are also there. One area which I want, especially the students and also the senior consultants to remember, is the role of the case manager. This is a concept that actually comes from social work, but it is very, very apt in rehabilitation psychiatry. See, the case manager is a person, the nodal sort of person who delivers as many services as possible for the person who is undergoing rehabilitation. This is especially so in community-based rehabilitation, but it can also be in institutional rehabilitation centers. So the case management uses natural community resource, whatever resources are available in the community, and the activity should be carried out at the community setting by the case manager. Individual and team case management are equally effective. You can, depending upon the clinical situation, one can decide which is more suitable. In all these rehabilitation plans, the case manager has the primary responsibility for all services. And by services, I mean not just monitoring drug regularity, or looking for a relapse, or looking for side effects, or looking for dysphoria, depression, suicidality, etc. in the patient, whether the person has the healthcare benefits that the state provides for him, otherwise to link him up to those benefits. If there is a medical problem, to link him to the appropriate medical services. All this stuff is done basically by the case manager, especially so in community-based psychiatric rehabilitation. And they work generally under the supervision of a professional, mainly to give directions in terms of little interventions that have to be done. But the case manager model has to have an appropriate caseload, because you can't burden him or her with 200 cases that have to be seen, or 200 patients to be seen in a community. That's not going to work. So in that sense, it becomes quite human cost loaded. You know, you require a lot of people to be involved. So it obviously increases costs. And it has to be a time unlimited service with round-the-clock accessibility. That's another difficult ask to fulfill. And there should be crisis management service in the case of a crisis. If there is a side effect, if the person is feeling very particularly upset, or is feeling suicidal, or is hostile, what is the crisis service that is provided by the case manager in the case management system, and to foster choice and to foster self-determination also here. So effective case management promotes continuity of care. It may be associated with smaller hospitalizations. You can manage that. When you have a case manager looking, quickly picks up an oncoming relapse, put the person in the hospital if it is necessary for a few days, stabilizes, sends him back again. So that sort of a thing can be achieved. And Cafe and Clet and other people have shown that. associated and it is associated with client and family satisfaction, this model, and it's associated, of course, naturally with an improved QAL. More intensive case management is necessary for clients with higher disability, whereas for those with lesser disability, the case management is far less intensive. And you focus on the strengths of the individual rather than on the deficits and disabilities. There are many models of case management. I'll just show you a slide. I don't know how clear it is for you. So on the left-hand side, you have brokered case management where they just refer you to different services. But towards the right side, you have assertive community treatment, and then further on to intensive case management. This is from Schizophrenia Bulletin. The students can find it in 98. The next important thing that you see in is how to look at treatment resistance. Now, a lot of our patients who need rehabilitation services have treatment resistance. Right now in our center, we have 14 people who are classified as suffering from treatment-resistant schizophrenia. And many of them have clozapine-resistant schizophrenia. So it is a fact, and we have to live with it, and we have to do something about it. So reported symptoms may be the treatment targets. The therapist has to openly predict the common misgivings that he or she has regarding how those symptoms may or may not respond. The confusion that often patients or clients have between illness and side effects need to be discussed very clearly. Other meanings that are attached to medications, whether they are cultural or whether they are ethnocultural in nature, need to be explored in order to reduce resistance to taking treatment. And the natural tendency to stop medications when well should also be discussed in order to talk about resistance. And then instilling the belief that poor adherence hurts. Poor adherence may actually worsen the situation for the individual. And you can use the metaphors. You can use the local language metaphors to explain things to them. I mean, in any language, you can find many of them. Next is the huge area which is now coming up. Some parts of it seems to be working, some parts not. I will spend a little time on this area. So neurocognition deficits in schizophrenia, we know, are in the domains of attention, vigilance, processing speed, working memory, verbal learning, all these things. And these are probably primary in nature. They're already there when the person manifests what we call clinically as a schizophrenic episode. So one or more of these deficits may be present, and they may correlate with disorganization, negative symptoms, poor functioning. So they are bad news. Similarly, social cognition refers to mental operations underlying social interactions. So perceiving social cues, interpreting them, generating responses to those social cues with and emotions with appropriate responses, knowing the intentions and dispositions of others. These are all the things that go with social cognition. And so in the domains of social cognition, like we said earlier about neurocognition, is emotional processing, social perception, social knowledge, attributional bias, theory of mind. All these things come under social cognition. So in the case of neurocognition, the repeated practice of elementary neurocognitive tasks is a restorative model for neurocognitive deficits. But teaching strategies that are not specific, designed to be employed in life settings, are the compensatory way, not the restoring, but to compensate for a particular loss. Environmental modification, whether using electronic or paper techniques, can be done. And current forms of training include remediation exercises, paper and pencil tasks, computer-assisted tasks, procedural learning, strategies to approach tasks, and individual or group format. Now, computer-assisted tasks can focus on attention, concentration, psychomotor speed, learning, memory, executive function, whereas clinician-guided will focus better on working memory, emotional perception, and executive functions. The training starts at simplest tasks and increases in complexity. And it's better done if you could gamify the tasks. If you could put a veneer of a game on the task, then it is more attractive for the client. invariably overlearning helps, like it helps all of us when we study. So it helps here also. At every step, overlearning helps. And of course, positive reinforcement works for us, works for our patients also. Individuated therapy is often better, though there are groups which have, people who have been using group-based interventions. Errorless learning is very, very important, that the person has to keep doing it again and again to see that there is 100% errorless learning. It's a bit like making a German car. It should be errorless. I'm not against Japanese or other cars or Indian cars, by the way. So use of procedural learning, because procedural learning lasts longer in us, it decays much slower. So try to use procedural learnings. That is important. Then effect training, overall this effect sizes are modest in nature, but they have a very moderate effect on psychosocial functioning. But cognitive training with comprehensive rehabilitation has better effect on psychosocial functioning. That means when you put it along with other rehabilitation techniques, other rehabilitation inputs, it does much better. It's not yet clear as to which client gets the, which client and which intervention is better. Right now, we are doing a shotgun sort of a thing. So it remains to be seen. Research has to tell us which particular client requires which particular intervention. That will make things easier. And as I mentioned, group interventions also give a large effect size, and compensatory cognitive training with environmental modification also has a fairly large effect size. These large effect sizes are from the context of rehabilitation. It is not in the context of treating an acute psychotic with neuroleptic medication. And environmental modification takes up a lot of time. It needs a lot of time of therapists. Restorative approaches also need a lot of time, but their generalization is still a little doubtful. The compensatory approaches are probably better in terms of results. Coming to social cognition, these deficits again are stable, just like neurocognition deficits. And there is poor social functioning in these people, and they may be attached to quantitative or qualitative biases. So one of the things that people have been talking about is metacognitive training to used for correcting the biases in thinking, especially when we talk about persistent delusions in a person with schizophrenia. You try to focus on trying a metacognitive intervention, provided he or she is a suitable candidate for that. That proviso is necessary. There are broad-based approaches like integrated psychological therapy, which addresses social perception, emotional perception, social problem solving, and so on. Whereas there are top-down approaches which focus on social cognition and metacognition, and bottom-up approaches focus more on neurocognition. There are targeted approaches which look at theory of mind, verbalization, affect recognition training, which has been very popular these days. One of our people has done the PhD on this also, using the training in affect regulation, or TAR. But the problem with these is that the generalizability is still questioned. So in summary, cognitive difficulties have a major impact on abilities from a rehabilitational perspective. Learning social skills is affected by cognitive disability. So even if you want to do social skills training, you may have to look at cognitive difficulties. Cognitive deficits affect rehabilitation process also, and higher order cognitive skills need attention specifically. Working memory, things like that need our attention. You can use either format, and computer driven versus paper and pencil driven. Many of our patients are more comfortable with paper and pencil. Some of them are now becoming comfortable with computer or smartphone driven applications. They can also be the therapist present versus automated. Personally, I feel the therapist present is better, but those who like to interact with a screen, maybe it works for them. And there are differences in the number of sessions that are needed, how long it has to go on. These are things research protocols are sorting out, and the type of training also. Very briefly about cognitive therapy of psychosis. And this is from Granholm. All effective programs are adjunctive to medications. This we must remember. And you can have individualized cognitive therapy It is shown to be effective in positive and negative symptoms like persistent hallucinations, persistent delusions, to some extent apathy and avolition, negative symptoms, and also to some extent in formal thought disorder. And the effects may last up to 6 to 12 months, but you need booster session. Now, remember this, however, that every patient who has formal thought disorder or a persistent delusion will not be able to be treated with this. You need a very, very, very narrow category of person who is suffering from those persistent symptoms, but is still able to engage in cognitive therapy. That's a big ask. It can improve collaboration with treatment. Of course, cognitive therapy for psychosis includes psychoeducation, and it leads to or tries to lead to normalization. However, some people have been studying cognitive therapies in psychosis for prodrome before the first episode. Its effect there is still not very clear. And you need to engage the person or the client for cognitive therapy. You need to avoid jargon. You need to find a common language and vocabulary suiting the educational level of the individual. Very, very simple, concrete examples of the rationale and very common goals have to be chosen. And always end the session with something pleasant or something happy for the client. Very briefly, this is one of the schemas that have been proposed, and there are many more, and there are many people working on cognitive therapies for resistant symptoms in schizophrenia. So where does cognitive therapy stand? At the bottom of this triangle is targeted CBT for CBT interventions, which is for the majority. At the top of the triangle is full-fledged CBT. So you know that top of the triangle, the number of patients are going to be much, much smaller. It's for the targeted specific tasks, not a gross change in behavior. You have targeted CBT. In between, you have cognitive therapy for hallucinations, delusion, negative symptoms, and then there are cognitive behavioral therapy informed interventions, which are a little higher up, and then coping strategy enhancement, nurse delivered interventions a little higher up, and then full-fledged cognitive behavior therapy. With all this, we need to remember that many of these therapies come from abroad and they do not have a local cultural mooring. So it has been suggested that even when you look at early life experience in cognitive behavior therapy, you need to have cultural factors in your mind. When you look at core beliefs and schemas, you need an ethnocultural reference group and cultural concepts which have to be kept in mind. Unhelpful assumptions, the meaning of symptoms in relation to the culture and the cultural idioms of distress have to be kept in mind. And the triggers, the meaning of symptoms in relation to culture again has to be kept in mind. When you talk about negative automatic thoughts, you should think about social stressors and help-seeking behavior, which is present for that particular culture. Then you arrive at the presenting problems. So you need to reformulate on the basis of the culture. Rathod has written a lot about it. She practices in England. She is an Asian-born, Indian-born person who has tried to devise cognitive therapy which is suitable for Asiatics living in England, and for students, they may want to read up what she has written. So regarding the guidelines for the adaptations, there should be a shared language. You can't do cognitive therapy in a person who speaks only Kannadiga in English. So you need a shared language, you need a shared culture of the therapist and the client to be able to understand the nuances, the metaphors, the context, and the concepts. The therapeutic alliance, pre-engagement through outreach is necessary. That means it breaks the usual therapeutic contract thing. You can go out and say, look, I have this intervention with me for your son or your daughter. Why don't you bring them along? You can tell the parents of the person who has the severe mental illness. And you need to work with the family and support system, which is often a no-no in Caucasian cultures. Then the cultural factors and the style in assessment is important, and also formulating psychological distress. I mean, what are the cultural idioms of distress from that culture needs to be kept in mind, and you need to extend the interventions beyond the dyad, beyond you and the client, into the family, into the community. So these are all adaptations to our sort of cultures. A little bit about avatar therapy, which unfortunately Julian Leff passed away recently. Avatar therapy involves computer avatars which are designed by patients with the help of mental health professionals to give a face to the voices that they are hearing. And these avatars then interact with the patient in a simulation of their persecutory voice on the screen. So then, under the direction of the therapist, the patients are encouraged to challenge the voices and allow them to gradually come under the patient's control. Now, it's a little difficult because it's not yet freely available and you need to pay for this. It's not freely available thing. They aren't yet selling it, but I heard that they'll be selling it by next year. It might be a very interesting thing for people who are dealing with people with severe mental illnesses of a chronic nature. There can be a dynamic way of looking at it, which is being talked about, a group analytical paradigm, where you understand the meaning of psychotic language in a psychodynamic sense. Why does this person say that two men and a woman talk to him all the time? What is the meaning from a psychodynamic sense, which is layered, of course. And then it requires very special training and very continuous supervision by another trained therapist. So the client and therapist subjective reports of improvement are there, but then this is just for the students to know. For improving further the functioning and this thing, I'm just putting this up for the students, where RE is basically re-educative measures, CE is cognitive enhancement, and SC is social cognition, and COMP is compensatory. So if you look at this, this is all evidence-based stuff, which shows improvement with all these combinations. I mean, you can go on and on. I hope that the organizers can give these references to the students there who can look up this stuff for their own knowledge. So I'll quickly go through this. This will anyhow go to you, the students. Yeah, there's plenty of work that has been done in this area. Now, next is to improve adherence to treatment. What do you do for improving adherence? Understanding the biological roots of the disorder, rationale of the pharmacological treatment, behavior and lifestyle changes that have to be made, mood charting in the case of bipolar disorder. How do you do mood charting? Much of this has actually come from the STEP BD work. Okay, so those of you who can read up about STEP BD will find all this, and awareness of comorbidities and their treatments and stress management, problem solving techniques. These are the sort of things that you look at in psychoeducation with bipolar disorder. Regarding cognitive therapy, you have evidence for cognitive therapy for depression in bipolar disorder. It's basically similar to cognitive therapy in plain depression, but you integrate the cognitive intervention with more extensive focus on promoting regular sleep, regulating extreme goal striving, and so on. Again, 12 to 18 weekly sessions, 2 booster sessions over 6 months, and then it is effective in establishing symptom reduction and improvement in relapse rates. Then there is family psychoeducation or family focused therapy, as it is called, which is being developed from the model for schizophrenia by Miklowitz and Goldstein. And this has been found, there is a lot of evidence for this, that it's a very structured sort of psychoeducation program where all the family members of the person with bipolar disorder are educated, and they're taught problem solving skills and so on and so forth. But it is definitely shown improvement in adherence and reduction in relapse rates. So this is an important rehabilitative intervention that you can look at. It's very highly structured and it's long. It's definitely very long. IPSERT, again, it has been around for a while. It's a modification of IPT of Klerman and Wiesman. You know that the resolution of current interpersonal problems like unresolved grief, interpersonal disputes, role transition, interpersonal isolation, these are all the tenets of IPT. Now, these are linked to social rhythms in IPSRT, and the results have been pretty good. Initial therapies are followed by maintenance sessions and so on. I'm afraid I'm taking up too much time, so I will hurry up a little bit. With resistant depression, there is a new kid on the block. CBASP is a cognitive behavioral analytical style therapy, psychotherapy, which has been designed specifically for chronic depression in the Western society. And they say the empirical evidence suggests that it is effective. But the whole problem is that it's a very rigorous training, and you need supervision by another trained person in CBASP. Similarly, for chronic OCDs that come into our rehabilitation setting, there are newer methods of short-lasting, intensive OCD treatment in very specified centers for OCD in the Scandinavian countries. So what are the trends? The central role of new mental health interventions are to reduce the burden of mental illness and related conditions. But you require a lot of resources for this. Individual therapy has been the most dominant thing, but then it is inaccessible to most people. Mental health research, so it is suggested by Kasdin, who writes a lot about this, should shift to develop several models of delivery using technology. That if you can develop other models, maybe you can reach out to more people, because you just don't have enough people to do all this. And the models needed for special settings, non-traditional service providers should be used, self-help interventions. You know, we heard of bibliotherapy and stuff like that before, similar things. Use of IT technology, integrating prevention with treatment, multidisciplinary collaboration. So these are the directions that probably we need to also look at when you look at rehabilitation and chronic mental illness. Now, we also have to look at the medical problems that these people have. Smoking, alcohol, diet, nutritional deficits, physical inactivity, weight management, the inevitable metabolic syndrome, general physical health care, vulnerable patients, vulnerable in terms of society, vulnerable in terms of gender, and so on, and maintain a very good liaison with medical specialties. So next important is the residential area. Where are you doing your rehabilitation work? Is it a rehabilitation ward, a hospital, a ward in a house, a daycare, a hospitalization, night hospitalization? It depends upon whom you are going to do work with. Core and cluster housing you can use. You can use a hostel, like we have one which receives some of the patients who are discharged from our rehabilitation center there, because the families are not yet ready to accept those people, or a clubhouse model, or a family placement model popularized by the remarkable Gill story, or adult independent placement where people do live by themselves, or group homes like halfway home, quarterway home, and so on, and supported housing. So you have all these locations or transitory facilities where the rehabilitation work can go on. And you have to look at the other important aspects, which are the social and health benefits, the demands for service users, work as a rights issue, because this is a big problem. When there are not enough jobs for people who do not have a mental illness or a physical illness, how do you ensure that a person who is competent but with a mental illness gets a job? It is his right, but are there jobs? That is an issue. Then economic benefits, and then the national healthcare policies make a lot of difference, especially in our country for BPL patients. And the role of work in social inclusion. If you want the person to get back into the community, work is extremely, extremely important. And rehabilitation services users are central to choosing their goals, and vocational schemes are also effective. But when you look at the story of employability, the mental health, people with mental health problems, the diamonds are so low as compared to those with physical health problems and those with the general population averages. Similarly, when you look here, you find that the persons who are employed least are the people who are on the top, the mental health people with mental health problems. Work again can be sheltered, pre-vocational training, supported employment, you name it. I mean, you can choose what you want. That's the thing. I mean, this is not everything for everybody. You have to choose your menu and follow that. You can have social firms, you can have opportunities for volunteering, service user employment programs, and so on. Now, the strategies for improving outcomes. Working with a client to find a job is very important. You can't just say, okay, go get a job. You have to work with him. Assisting him in preparing an application if it needs an application. Assisting in preparing for an interview. We've had to sit and mimic an interview with patients and then make them practice how to answer questions. Simple questions. Helping regarding disclosure of illness, whether to tell disclosure of the illness or not. That's a big issue when you want to go out to work and you have an SMI. Practicing simulated phone calls if you need to use the phone in your workplace. Assisting in daily challenges like getting ready on time, dressing properly or adequately for that particular work setting. High availability for support soon after employment. You have to keep high availability of support. And importantly, place and train. The days of train and place are gone. So it is place and train now. The team, you need psychiatrists, clinical psychologists, social worker, occupational therapist, vocational trainer or counselor, nurse, general duty worker or housekeeping people, administrator, agencies and services, both NGO and governmental, volunteers and others. It's a huge, huge area, a huge number of people involved. And the tasks involved: removal of symptoms, recovery, quality of life, frequency of use of hospital services. Importantly, what are the stages? At the stage of feasibility and acceptability, you do an audit. We've done an audit in our service and we found fairly good results. We'll be publishing it soon. Inquiry into the problem is an observational study, but we are doing an outcome assessment and a follow-up with a follow-up cohort, and that should be coming out by mid next year. Intervention, dissection, exploratory trials can do which is better. This is better or that is better. Confirmation of efficacy, you need a large-scale trial with a control group, which becomes very difficult in real life. Then you have to look at the audit of standards for constant monitoring, whether it is happening or not. And then internal dissemination, policy and promotion. Very briefly about our center, this is one view of Hombelaku, which is the morning ray of sun. And this is the old building, and this is the new building, which is mainly special wards or special rooms with attached bath, where we are going to cross-subsidize our patients in the general ward. Our team has part-time psychiatrists, part-time psychologists, social worker, occupational therapists, trainees of the allied mental health specialties, nurses, vocational trainers. This is what we have. And this is their daily routine, which is followed probably around 75 to 80% of the time. Looks very onerous, but yes, we need to get them into that particular thing. And then we have non-daily programs for them, including weekly, monthly, and then on special occasions and so on. Various things, various schemes for people who are within. And we also do interesting things like taking them all to a nearby supermarket, making them to make a list of the things they need to buy for that month and the money that they have. And then they're taken there and they choose. And then they are made to calculate how much money is in their hands, or what they can afford and what they cannot afford. And then you buy it from this thing under supervision of our people. And this happens every fortnight. It teaches a lot of things. It teaches coping, it teaches skills of communication, money matters, and so on. So these are some of the things that happen routinely for all patients. Of course, we celebrate various days and stuff like that. There are activities in-house for people who cannot go out, and there are activities for people who can go out. And we have used our community for providing us chances for training in shops, in malls, in restaurants, in offices, and so on and so forth. Very briefly, our 10-year experience. We've had a total of 578 admissions in our residential care, and about a quarter of them have had readmissions. Most of them are from Karnataka. Most of them are referred by mental health professionals, some by police, some by welfare agencies, and some by ex-patients or directly through the Facebook page. Diagnosis-wise, severe mental illness is obviously top the list. Males outnumber females, which is probably a comment on the accessibility of mental health care for men and women differential in our society. The minimum stay has been 1, the maximum 3,000. The average is something like about 6 months plus. Okay. 12 residents have stayed for a very long time. These are people who the families were not willing to take back. A whole host of therapies that we have used so far at individual and at group level, and other interventions which are exceptionally important, like recreational activities, client-centered film shows, selected film shows, de-stressing and de-burnout for our staff, monthly family educative and interactive meetings, and so on. So these are all stuff that I've been talking about, which we use in our center. And these are the vocational activities. The top one is for people who cannot go out, who are not able to go out to work. We have a variety of activities which have gone on into trades for them once they are discharged. And then they have clerical, hotel, salesperson, so on and so forth. Our model utilizes the society that we are in, the community, and what the community has to offer in terms of option. And the community has been extremely kind to our center. Mortality, yes, we've had 29 deaths during this 10-year period, 7 of them at the center, out of which 3 were suicides, which is very unfortunate. And deaths after return to the community are 22 for various reasons, not suicides, medical causes, and so on. Post-discharge, we have follow-up with 206 people. We are maintaining about 38 are following up elsewhere. We don't have contact with a fair number of people, unfortunately, and about 36 are placed in other institutions. Next is a very important development that we started, which is a community-based thing called the ACT program, or Assertive Community Treatment. The actual assertive community treatment, which was started in the US, is listed. The activities are listed out in the left side column, or rather the middle column, and the Manipal ACT is in the right-sided column. So it's more or less similar, except that the client to mental health worker ratio is much larger in our case. And we also take not only people who need frequent hospitalization, but severe dysfunction needing residential and rehabilitation services. So the clientele have the age group of 10 to 50. Currently, we are doing 30 people, but we are hoping in the next year or two to expand to the whole Udupi Taluk. We are looking for funds. We have written for grants for that. So predominantly it is psychosis, predominantly it is people with longer illnesses and people who have had larger number of admissions. The reasons for referral: medication compliance, enhancing support, establishing routine, vocational rehabilitation. And usually the reference is for multiple reasons. Now, interestingly, if you look at the data before the MCAT started and after, you find that there is an improvement in the SOFA scores, there is an improvement in the IDEA scores, there's a drastic decline in admissions of these people. And the duration, if they are admitted, the duration of admission is reduced and adherence is remarkably improved. Of course, I agree with you that 30 is a small sample, but then it shows that there is some place for this sort of ACT type of program in our patients also, in our communities also. So finally, in conclusion, there are several developments in psychosocial and psychological interventions for the chronic mentally ill to mitigate suffering and facilitate rehabilitation. However, when it comes to drugs, we seem to have reached a ceiling of efficacy with conventional treatments. Some interventions are yet theoretical and others are practical in nature. Some of the interventions require our updating our skills to be able to deliver them to our patients. Though effect sizes are modest to good, they do appear to make a sizable difference in patients' lives. All of these interventions are augmentation strategies to standard care. None of them is a standalone. We need to negotiate and renegotiate the goals as work progresses in rehabilitation. We need to maintain a balanced therapeutic attitude, paying attention to rights, aspirations, stigma, inequity, discrimination, which is all there in the society. It needs a collaborative decision-making on everything, on residential stay, on occupation, transitional arrangements. All of them have to be collaborative. Continuity of care is extremely important. If you're starting out on rehabilitation work, you need to have continuity of care. It is indefinite and it is necessary. And we need to create avenues for personal growth, recovery, and prevention of burnout, both for the clients whom we are serving, as well as the workers who are working, mental health and other workers who are working in this area. And finally, we need to know our limitations. We need to be pragmatic. We need to appreciate slowness of change and be ready for crisis and setback. Very important. The process is often more important than the endpoint in rehabilitation and psychiatry. I want to acknowledge the contributions of R.K. Bandari and Praveen for giving me the data of the last 10 years of Humbeluku and the ACT. And I thank you for a very patient hearing. I thank the Khammam Psychiatric Society again for giving me the honor of the Bhujanga Rao Third Oration Award. Thank you very much.
Thank you, Dr. Sharma, for your very elaborate and very systematic way of presentation, going into details about, the goals of rehabilitation, how to select, and I think it's the types of training we need to look into, and then the various models, which are very, very important. Unless we have the models, we'll not be in a position to really plan and organize the therapies. And one thing which you highlighted throughout is that it is, collaborative approach with various, systems. And you also spoke about specific interventions, which involves the management of the individual client, the family, and the whole environment. And very important thing is, I think relationships. It's a relationship between the client, the therapist, and the family and everybody. That's very, very important. Unless we improve the relationships, naturally the person will not be accepted or person will not integrate. So that aspect you nicely highlighted. You spoke about individual, how you go about the case management, and then you talked about the techniques, and also you highlighted how the cultural concepts ought to be taken into consideration, because most of it, we know the models which we get is from the West. We can't strictly follow what exactly is there. I think we need to modify according to our culture and our expectations from the families, and with the feasibility of applying those models to our culture. And one thing which I appreciated is the holistic approach of not only the psychological, occasional. You also talked about the physical comorbidities. Most often we see throughout, anywhere we don't really, the psychiatrists, we generally ignore about the physical health, I think, which you highlighted, which is very important. And one thing which I was remembering, I read a document which Dr. Raman gave it to me before I went to NIMHANS. I read quite a few articles from him before I went to NIMHANS. One thing is a document written by Dr. Bhaskaran. He was, I think, first director of Ranchi. Beautifully, he said the same words which you mentioned. The rehabilitation starts with the first treatment, the first contact with the patient. I still remember this because I asked Dr. Raman Rao, how is it? The moment patient comes, how can you think about the rehabilitation? Because they're quite immature, and I didn't even enter the psychiatry. So this really impressed me. I still remember Dr. Bhaskaran for that. And from where we have gone to, first we are thinking about the recovery of the symptoms. Then we went on to the quality of life. Then we are thinking about quality of life, reintegration to society. That means we are going beyond, thinking wise, the philosophy wise. But as you say, it involves multidisciplinary approach and the passion and collaborative approach. And I think you wonderfully highlighted, and you practically told us how it can be done, and your own experience and the results, quite impressive, I would say. Like supposing each center takes up things like that and spread it across, and especially if the families are really educated, I'm sure, the rehabilitation process becomes a little more easy. making it acceptable to the families. I would say that. I think with these remarks, if the president allows, I think there seemed to be one question, I'm not very sure. Generally, orations are, without questions. And if the president allows it, maybe I don't mind asking the question.
Okay, madam. Okay.
I don't know. Oh, yeah. What is the genetic basis for schizophrenia? Nagamani eventually asked. I think it's beyond the scope of the present, the talk. I think, you can have it. Lots of, research work is there. I think you can Google into the quite a few review articles. I think you will get the genetic basis very well. I think it's not pertaining to related to this topic, and so sorry, will not be entertaining. Thank you.
Thank you very much, sir, for your excellent presentation. As Madam has described, you have covered everything regarding the rehabilitation, and thank you very much for giving your rehabilitation center details also. And thank you, Madam, for your time and for your excellent this thing. And I thank all the participants. And I would like to, I want to ask Dr. Pradeep, sorry, Dr. Pramod Kumar Reddy for a vote of thanks.
Honorable dignitaries on the dais and off the dais, my senior and junior colleagues, ladies and gentlemen. It is my profound privilege to propose vote of thanks to the August gathering on behalf of Common Psychiatric Society for Dr. K. Bhujanga Memorial Oration. I sincerely thank Dr. P.V.S.N. Sharma, Speaker, P.S.V.N. Sharma, Speaker, for immediately accepting our request to be the recipient of our oration and taking time to be with us on the auspicious day for us. I thank from bottom of my heart our chairperson, Dr. Gauri Devi Garu, Asha Hospital, Hyderabad, for chairing the session. I thank our chief guest, Dr. Ram Subba Reddy, President IPS Telangana State Branch, for gracing the occasion. I thank guest of honors, Sri Dr. Pavan Kulakarni, Honorable Secretary, Indian Psychiatric Society, Telangana State Branch. I appreciate the efforts of our sponsors, present formulations for making all the arrangements. I thank our very own members who made this event successful. We also thank our Common Psychiatric members, mainly Dr. Satish Babu Garu, President of Common Psychiatric Society, Dr. Narayan Rao Garu, Dr. M. Raghuram Garu, Treasurer, and Dr. Virender, Joint Secretary, who helped make this event successful. Thank you for one and all.
Thank you and good night.
Thank you, sir.